Hello everyone. So our next topic of discussion is bile. So bile is composed of bile salt, phospholipid cholesterol, bilirubin, water and ions. This is the composition of bile and it is stored in gallbladder. So what are bile salt? When bile acid combined with glycine and taurine, it makes them water soluble. It's called bile salt. When acid combined with glycine and taurine, that make bile salt. What is the rate limit? So bile salts are formed by cholesterol. So cholesterol use 7-alpha hydroxylase rate limiting enzymes for the synthesis of bile acid. So cholesterol 7-alpha hydroxylase that results in bile acid synthesis, and then this bile acid combined with glycine or taurine to form bile salt, which are water soluble. So bile salt synthesis, you can see cholesterol. This is the rate limiting enzyme 7-hydroxylase. It forms 7-hydroxy cholesterol synthesis combined with cholic acid. So that results in the formation of cholic acid and cholic acid, which both can combine with glycine or taurine, resulting in formation of bile salt. What is the function of bile salt? Digest fat. You can digest fat, absorption of fat, soluble vitamin. Next is pancreatic secretions. We are discussing about physiology, pancreatic secretion. So pancreas secrete different kinds of enzymes. So first is amylase. Amylase is responsible for carbohydrate digestion, secreted in active form. Lipase, fat digestion. Protease, protein digestion. So protease is secreted as proenzyme. It's not secreted in active form. Trypsinogen, again protein digestion. It is secreted in active form. Inactive form. So trypsinogen is inactive. It is converted into active form, which is trypsin, and it is converted into trypsinogen is converted into active form trypsin by enzyme called enterokinase or enteropeptidase. And then trypsin is responsible for protein digestion. Next is liver function test. So if there is a liver damage, so these are the markers of liver injury. If there is damage to hepatocyte of the liver, which are the cells of the liver, then AST, ALT will be elevated. These are the marker of liver injury, AST, ALT. If they are high, that indicate liver damage, liver cell necrosis, hepatocyte damage. What are the causes? Viral hepatitis, alcohol-induced damage. So these are two common causes. Or drug-induced. What is cholestatic pattern? So if AST, ALT is elevated, that indicate liver injury, hepatocyte injury. If ALK phos and GGT, they are elevated. That indicate injury to biliary tree, gallbladder, common bile duct, hepatopancreatic duct. So cholestatic pattern. So if there is an injury to gallbladder, right and left hepatic duct, common bile duct, that indicate cholestasis. If there is an injury to that tree, then ALK phos and GGT will be elevated. Now, what are the markers of liver function? How well liver is functioning? So for that, you have to see serum albumin level, because albumin is synthesized by the liver. So if the liver is completely damaged by cirrhosis, albumin level will be low. Prothrombin time. In case of, so liver is also responsible for the formation of clotting factor, and prothrombin factor is also produced by liver. If liver is damaged, it has a very short half-life, and it will be abnormal. So increase prothrombin time in liver disease. Factor 5, again the clotting factor, it is decreased in severe liver disease. BUN, so urea cycle is present in the liver. If there is a damage to the liver, BUN will be high in cirrhosis. Serum ammonia level, ammonia is metabolized by the liver and converted into urea. If liver is damaged, ammonia level will be high. So these are the marker of liver function. Next is bilirubin metabolism. So let's look at this. So we have blood vessel, and in the blood vessel we have RBCs. So when the RBC are damaged or rupture, heme will be released, or hemoglobin. So this hemoglobin will be converted into bilirubin, and this bilirubin will combine with albumin, which will make it water soluble. But this bilirubin plus albumin will be unconjugated. This unconjugated bilirubin will go to liver, and inside the liver there is an enzyme called UDP, glucuronidase, which will convert unconjugated bilirubin to conjugated bilirubin. Sorry, so here unconjugated bilirubin is this is right. So conjugated bilirubin will be excreted into biliary tree, bile duct, and then go to the intestine. And in the intestine, conjugated bilirubin will be converted into urobilinogen. So 80% of the urobilinogen will go into the feces, and this urobilinogen will be converted into stercobilinogen, which will give brown color to the stool, stercobilinogen. So this 80% goes here, and then 20% of this urobilinogen will go to the kidney. And in the kidney, it is converted into urobilin. which will give yellow color to the urine. So let's discuss this. So I wanted to give you the summary. So unconjugated bilirubin. So RBC undergo degradation in the spleen. Unconjugated bilirubin is the end product of metabolism of heme in the macrophages. It combines with albumin in the blood and go to liver hepatocyte. The liver hepatocyte, they will uptake unconjugated bilirubin and conjugate it with uridine glucuronosyl transferase enzyme to produce conjugated bilirubin. So conjugated bilirubin is created into the bile, go to the intestine, converted into urobilinogen, where 80% go to the feces, converted into stercobilin. Rest of the 20% will go to the kidney, converted into urobilin, which gives yellow color to the urine. And here, when it goes to the feces, it is converted into stercobilin, which gives brown color to the stool. This is again the same thing, but just summarized in the diagram. So in the blood vessel, hemolysis, unconjugated bilirubin combined with albumin goes to the hepatocyte. This is hepatocyte. In the hepatocyte, conjugation occur with glucuronic acid, UTP glucuronide transferase enzyme converted into conjugated bilirubin, goes to the biliary system, enter the small intestine here. In the intestine, bacterial protease convert bilirubin into urobilinogen, goes to feces, stercobilin, and then goes to kidney, urobilin, and then rest is absorbed back into the portal vein. So this is the bilirubin metabolism. Now, how jaundice occur? So if you remember this pathway, you can easily understand jaundice. It's a symptomatic disease which is caused by increase in unconjugated or conjugated bilirubin. Unconjugated bilirubin, which is produced in the liver, is water soluble. It's also called direct bilirubin. Unconjugated bilirubin is lipid soluble. It's also called indirect bilirubin. Sclera has high affinity for bilirubin, which is why in jaundice there is a yellowish discoloration of sclera because of elevated bilirubin. Now, what is prehepatic jaundice? So we are talking about, this is blood vessel, RBC, hemolysis, and unconjugated bilirubin goes to the liver. So prehepatic, before they go to the liver, so we have unconjugated bilirubinemia. So what is the cause of unconjugated hyperbilirubinemia? Excessive hemolysis. If there is increased RBC rupture, that will cause unconjugated bilirubinemia. Or let's say if there is a decreased uptake of this unconjugated bilirubin in the liver, if there is a decreased uptake, that will cause prehepatic jaundice. And the jaundice will be caused by unconjugated hyperbilirubinemia. Because unconjugated hyperbilirubinemia is not water soluble, therefore it will not appear in the urine. So if you check the urine for bilirubin in prehepatic jaundice, urine bilirubin will be absent. What are the causes of prehepatic jaundice? The most common cause is hemolysis. What are the causes of hemolysis? Hemolytic anemias. Second important cause will be decreased uptake or conjugation of unconjugated bilirubin. And the example is Gilbert syndrome, Crigler-Najjar syndrome, physiological jaundice of newborn, breast milk jaundice. So let's say the decreased uptake. So let's say this is blood vessel, this is liver, and at this point the liver is not uptaking unconjugated bilirubin here. So this process is stopped. So there are two main types. So in the liver, there is an enzyme called UDP, glucuronosyl transferase. If this enzyme is absent, which is responsible for conjugation of bilirubin, that will result in increased unconjugated bilirubinemia. Number one is Gilbert syndrome. Second most common cause of jaundice after hepatitis, impaired UGT activity or decrease in activity. Jaundice occur in fasting, menses, stress, volume depletion. So in these kind of situation, especially in stress, just remember in case of stress, unconjugated bilirubin go up, common in Gilbert syndrome. Crigler-Najjar syndrome, so again, decrease or absent UGT is not compatible with life, require liver transplant. Autosomal recessive disease. Physiological jaundice of newborn began on third day of life, caused by normal destruction of fetal RBC containing hemoglobin F. So because of normal destruction of RBC, bilirubin will go up, and the liver is still immature, and it will not uptake bilirubin, which will result in excessive unconjugated hyperbilirubinemia. It's a physiological jaundice of newborn, usually in 48 to 72 hours. Liver is immature, will not uptake bilirubin. Breast milk jaundice. So breast milk, basically it has activity which will cause unconjugation of, which will inhibit the activity of UDP glucuronosyl transferase. It inhibits the enzyme which is present in the liver, UDP glucuronosyl transferase. So breast milk can inhibit this enzyme, which will result in increased unconjugated bilirubinemia. So treatment, use formula milk until liver is more mature. Mixed jaundice will not do. We'll go over obstructive jaundice. Now, what is obstructive jaundice? So we have this liver, right hepatic duct, left hepatic duct combined to form common hepatic duct combined with cystic duct. Gallbladder, cystic duct combined with common hepatic duct to form common bile duct. So if there is an obstruction in the biliary tree, that will cause obstructive jaundice. So that will result in increased pressure in the hepatic. So let's say there's obstruction here or obstruction here. The intrahepatic bile pressure will go high, and bile will go into the sinusoid, which is blood. So in that kind of situation, when there is obstruction, there will be absent urine urobilin because of obstruction. Why? Because the conjugated bilirubin which is formed in the liver is not getting released. So when the conjugated bilirubin is not there, there will be no urobilinogen or stercobilinogen in the stool, which will cause clay color stool. And then there will be dark urine. So urobilin, because urobilinogen will go to the kidney, converted into urobilin. If urobilin is not there, the urine will be dark, because urobilin gave light yellow color to the stool. If it is not there, dark urine. Cause of obstructive jaundice: decreased extrahepatic biliary flow because of the gallstone, carcinoma of the head of the pancreas. So we have gallbladder, common bile duct. So let's say there's a stone here, bile will not move forward, decrease extrahepatic biliary flow. Let's say if there is a duodenum, second portion of the duodenum open into the combined with pancreatic duct, pancreas here. So if there is a carcinoma of the head of the pancreas, the duct will be obstructed, decrease extrahepatic bile flow. And second is decrease intrahepatic bile flow. Whatever is flowing inside the liver is obstructed. Can be because of the drug, primary biliary cirrhosis, Dubin-Johnson syndrome, Rotor syndrome. That can also cause obstructive jaundice. What is Dubin-Johnson syndrome? Autosomal recessive disorder. A transporter which transports bile into intrahepatic bile duct is defective. What if there is a mutation in apical canicular membrane protein responsible for excretion of bile? You will see black pigment in lysosome of hepatocyte. So in Dubin-Johnson syndrome, you will see pigmented liver because of the black pigment in lysosomes of hepatocyte. Next is Rotor syndrome. Autosomal recessive disorder similar to Dubin-Johnson syndrome but without black pigment in hepatocyte. So this is how the histology look like. Dubin-Johnson syndrome. In Rotor syndrome there will be no black, but in Dubin-Johnson you will see black pigmentation. Next is circulatory disorder of liver. So if there is a hepatic artery thrombosis, common in liver transplant, polyarteritis nodosa, that will result in infarction of the liver. So patient will present with severe abdominal pain. Portal vein thrombosis causes hepatocellular carcinoma is very common. Polycythemia vera is again very common. Pylophlebitis not very common. So obstruction to blood flow to the liver via hepatic artery or vein result in hepatic artery. So the cause are most commonly hepatic artery thrombosis and portal vein thrombosis. Intrahepatic obstruction of blood flow caused by cirrhosis, sickle cell disease, centrilobular hemorrhagic necrosis, Pilosis hepatis, sinusoidal dilatation due to blood causes anabolic steroid Bartonella henselae causing bacillary angiomatosis in AIDS patient. So this is not very common, so they will not ask you about this.